Hey everyone, today we're going to tackle a topic that is incredibly high stakes, thoracic trauma, a major chest injury. What you do in those first few moments, well, it's not just important, it can literally be the difference between a patient living and a patient dying. So let's dive right in.
So, just how serious are we talking? We'll get this. 1 out of every 4 trauma deaths is from a chest injury. 1 in 4. Let that sink in for a second. That means for every 4 trauma patients who don't survive, 1 of them is lost because of the exact kind of injury we're talking about today. The pressure is on from the moment they roll through the door.
But here's the thing, and this is so important. A lot of these deaths don't have to happen. They are absolutely preventable. This isn't about some random chance. It really comes down to you understanding what's going on in the body and knowing how to step in, and step in fast. What we're going over today, this is knowledge that you will use to literally save lives.
Okay, so here's our game plan. First, we're going to look at what's actually going wrong inside the body. Then, we'll walk through the essential management plan. And finally, we'll really focus in on the primary survey, your good old ABCs.
All right, let's get into the why behind all of this. You can't fix something if you don't know why it's broken, right? We need to understand the chain reaction that a major chest injury sets off. Once you really get this, making the right calls when everything is chaotic becomes a whole lot easier.
So, the biggest, baddest enemy we're fighting here is something called tissue hypoxia. And it's a really simple but really brutal concept. The body's tissues are literally suffocating. They're not getting enough oxygen. And this can happen for a few reasons. Maybe there's been a lot of blood loss, maybe the lungs themselves are injured, or maybe there's a dangerous amount of pressure building up inside the chest.
And at the very same time, something else is happening, hypercarbia. All that means is there's way too much carbon dioxide building up in the bloodstream. You should think of this like a giant flashing neon sign that screams, this person is not breathing well. It's the classic signal of what we call hypoventilation.
Now, that CO2 buildup doesn't just hang around. It has a real chemical effect. It leads directly to something called respiratory acidosis. Basically, the blood itself starts to become acidic. And when that happens, the whole body's chemistry gets thrown off, and that starts messing with all sorts of other vital functions.
But it's like we're fighting a war on 2 fronts here. Because on top of the breathing problem, you've also got metabolic acidosis. This one isn't coming from the lungs, it's a circulation issue. When the tissues aren't getting enough blood flow, shock, they start making their own acid. It just piles on and makes a bad situation even worse.
Okay, so let's make this crystal clear. The acidosis? Yeah, it's a huge problem for sure, but it's a symptom. It's a consequence. The real killer, the thing that will end a life in minutes, is the tissue hypoxia, that lack of oxygen. Your number 1 job, your only job at the very beginning, is to fix that. Get oxygen to those tissues. Everything, and I mean everything else, is secondary.
So we've identified our main enemy, hypoxia. Great. Now, what's our plan of attack? When you're in a trauma situation and everything feels chaotic, you absolutely need a structure to follow. This 4-step plan is going to be your roadmap.
And the plan is nice and simple, you just follow it in order. First up is the primary survey. This is where you're looking for the things that are going to kill your patient right now. Next is resuscitation, where you actually fix those things. Then you got the secondary survey, which is that more detailed head-to-toe look. And last is definitive care. For our purposes today, we are laser-focused on that very first step, the primary survey.
Okay, so the primary survey, this is all about your ABCs. And let me be clear, the order is absolutely non-negotiable. You always start with A for airway. It's simple, right? If air can't get into the lungs, nothing else you do is going to make a bit of difference.
So, when you're standing over that patient, what are you actually looking for? What are those key signs that tell you in just a few seconds whether that airway is open and working?
Think of it like a quick 3-point check. First, you're going to use your ears and your sense of touch. Get your face down by their mouth. Can you hear or feel any air moving? Okay. Second, you're going to use your eyes. Look at their neck and chest. See those muscles between the ribs or above the collarbones getting sucked in? Those are called retractions, and they're a huge red flag for trouble. And third, if the patient isn't awake, you need to open their mouth and look inside. Make sure there's nothing obviously blocking the way.
Okay, let's say the airway seems clear. A is good. Now we move on to B for breathing. And this is a key point. Just because the airway is open doesn't mean the breathing is effective. So now the question becomes, is the patient actually breathing well?
So what does that look like? How do you actually check the quality of their breathing? What are you looking for?
First things first, you got to expose the chest. You can't assess what you can't see, so get those clothes off. Then you use all your senses. Watch the chest rise and fall, feel it with your hands for anything that seems off, and listen for breath sounds. Take a look at the breathing rate. Is it super fast? And probably most important of all, look at the pattern. If you see someone taking really fast, shallow breaths, that's a sign they're getting tired. And that, my friends, is a full-blown emergency.
And listen, I need to tell you about a huge clinical trap you have to avoid. We all learn in school that low oxygen makes people turn blue, right? Cyanosis. But here's the reality. That is a late sign, like dangerously late. Your patient could be circling the drain from hypoxia and still have perfectly normal-looking skin color, so please, please do not wait for your patient to turn blue to act.
Okay. Airways patent. Breathing is assessed. Time for C. Circulation. We need to know if the heart is pumping effectively. Is blood actually moving around the body like it's supposed to?
So what are the quick checks you can do to get a picture of the circulation?
Here's your quick checklist. First, feel for a pulse. What's the quality like? Is it strong and steady, or is it weak and fast, what we call thready? Next, get a blood pressure. Then check their skin. Is it pale, cool, maybe a little sweaty? That's the classic textbook sign of shock. Take a glance at their neck veins. And of course, get that patient hooked up to a cardiac monitor right away. We have to see what the heart's rhythm is doing.
Okay, time for another one of those clinical pearls, another trap to avoid. You probably learned that with cardiac tamponade, that's when there's pressure building up around the heart, you'll see big, bulging neck veins. And that's true. But what if your patient has also lost a lot of blood? If they're hypovolemic, their veins might be totally flat, even while their heart is being squeezed by that tamponade. It's a really tricky combination that can easily fool you, so you have to be suspicious.
You know, one of the scariest things you can ever find is something called electromechanical dissociation, or EMD. Here's what happens. You look up at the monitor and you see a heart rhythm. It might even look pretty normal. But then you reach down to feel for a pulse, and there's nothing. Absolutely nothing. It's like the lights are on, but nobody's home. The heart's electrical system is working, but the pump itself isn't. And the things that cause this, they're the absolute worst-case scenarios. A cardiac tamponade, a tension pneumothorax, just profound blood loss, or even a rupture of the heart itself.
So there you have it. That's the primary survey in a nutshell. A, B, and C. You now know how to look for a blocked airway, for breathing that's failing, and for circulation that's collapsing. And you know some of the tricky signs that can throw you off. But in the end, it always circles back to that one single question. Since we know that hypoxia, that lack of oxygen, is the thing that's going to kill our patient first, what do you do first? How do you decide what's most important when it feels like everything is falling apart at the same time? And that's the real challenge.